we would like present on arthroscopic ankle fusion in the post-polio paralytic foot. None of the authors received financial grants for this study. Advantages include smaller incisions, reduced scarring, thereby better cosmesis, faster recovery, less postoperative pain, lower risk of wound infection, does not require a distraction device and can be performed with a usual 4 mm 30-degree arthroscope, better outcomes than open fusion with lower overall cost. Disadvantages includes requirement of advanced surgical skills and specialized equipment, limited surgical visualization in complex deformities, and is not suitable for severe deformities or large bone defects. The patient is positioned supine on the operating table under spinal anesthesia, with a bump placed under the ipsilateral hip to maintain the foot in a neutral position. A pneumatic tourniquet is applied at the appropriate pressure. The ankle to be operated on is carefully positioned to dangle off the edge of the table, enabling free movement throughout the procedure. After sterile preparation and draping the operative extremity, with the use of a sterile marking pen, the relevant anatomical landmarks are marked out, including the lateral malleolus, medial malleolus, anteromedial portal, anterolateral portal, the superficial peroneal nerve depicted by the fourth toe flexion sign or Stevens sign. The anteromedial portal is created at the joint line, medial to the tibialis anterior tendon in the palpable soft spot, aided by ankle dorsiflexion and plantar flexion. A blunt trocar is inserted with the ankle dorsiflex to avoid cartilage injury, and joint visualization is performed. Of note, the saphenous vein and nerve crosses the ankle joint along the anterior edge of the medial malleolus and may become injured during placement of the anteromedial portal. The anterolateral portal is established under arthroscopic guidance at the joint line, lateral to the peroneus tertius tendon, ensuring protection of the superficial peroneal nerve. Portal usage can be swapped based on the surgeon's preference. After successful anteromedial and anterolateral portal entry, diagnostic visualization of the tibio-talar joint comprising the tibial plafon as well as the talar dome is performed. The evaluation carefully assesses for the presence of any osteophytes, loose bodies, or osteochondral lesions of the talus and tibial plafon. A 3 mm shaver is used to debride interposing soft tissue to aid clarified vision. In our case, the arthroscope is maneuvered across the notch of Hardy followed by down into the medial gutter that reveals narrowing of the medial joint space, denuded cartilage, arthritic changes with small and soft bones along with anterior surface of flexor hallucis longus tendon. All the remaining articular cartilage are denuded with a shaver, lavaged out from the joint until subchondral bleeding spots are seen both in the talar dome as well as the undersurface of tibial plafon. Manual reduction of the ankle is held and maintained in neutral dorsiflexion, 5-degree eversion, and 10-degree external rotation using a Kate wire. Continuing maintenance of the reduction of the tibio-talar joint along with considering the small size of the polio limb as well as the bones, 3 guide wires for the 6.5 mm compression screws were inserted, initially starting from centromedial distal tibia to anterolateral talar neck. Secondly followed by posterolateral distal tibia to anteromedial talar head, and finally directed from posteromedial distal tibia to anterolateral talar neck in converging configuration, confirmed under fluoroscopy. Subsequently, after making necessary skin incisions, measuring and drilling, the determined size screws are placed, making sure to verify adequate bone purchase and compression of the ankle joint with no screw extrusion in the subtalar joint surface under fluoroscopic guidance. Whereas open ankle arthrodesis involves large incisions, extensive soft tissue damage, high post-operative pain, high risk of infection, longer recovery period with comparable fusion rates, the arthroscopic ankle arthrodesis benefits from smaller incision, minimal soft tissue disruption, reduced post-operative pain, lower risk of infection, faster recovery with shorter hospital stay as well as high fusion rates with less morbidity.